The present topic of discussion, it is on bone diseases that are seen in oral cavity. So here in this discussion, we will be talking about some important topics, that is osteogenesis imperfecta, fibrous dysplasia and cementoosseous dysplasia. So of the three, first we will discuss about osteogenesis imperfecta. So this osteogenesis imperfecta, it is also called as brittle bone disease or Lobstein's disease. So before going into the disease, we shall discuss about in general about bone, wherein we know that a bone matrix, it is formed by both organic and inorganic components. So in the organic matrix, the main component is type 1 collagen, that is a predominant component of organic matrix, where after collagen is laid down, on top of which the calcification will occur, that is the inorganic component will occur in the form of hydroxyapatite. So in case of osteogenesis imperfecta, this type 1 collagen will be defective or it is abnormal, resulting in defective bone formation. Why is this defective here? Is because of mutation in the genes which produce the type 1 collagen. So those genes are nothing but COL1A1 and COL1A2. These two are the main genes which will produce type 1 collagen, where these genes will be mutative. So because they are mutated, they result in the formation of type 1 collagen, which is defective in terms of both quality as well as quantity. Okay, so because of this qualitative defect, the immature collagen, that is the fetal collagen which is formed, there will be failure of this fetal collagen to transform into mature collagen. So whatever collagen will be formed will be in the form of an immature collagen only, because of which there will be various symptoms that are seen in osteogenesis imperfecta. Those symptoms will be in the form of osteopenia, fractures and sometimes defective healing of the bone. These are general features. Now let's see clinical features of osteogenesis imperfecta. So before going into clinical features, where all this type 1 collagen will be seen in the body, it is predominantly seen in case of bone, sclera of the eye and dentin of the teeth. So these three are the main structures in the body where type 1 collagen is predominant. So type 1 collagen, if it is defective, these three will become defective then. So if you see bone, a bone will show extreme fragility as well as porosity within them. Okay, so if you see this picture where there is a comparison between healthy bone and the bone in osteogenesis imperfecta, so the bone in osteogenesis imperfecta, it is more porous compared to that of the healthy bone. Because it is more porous, it results in tendency to fracture is more within osteogenesis imperfecta. And if you see sclera, sclera will be pale blue in color. Pale blue sclera will be seen in osteogenesis imperfecta. Why? Because the sclera which will be formed will be very thin. So because of which the background, that is choroid, which is blue in color, will be shown through this thin blue sclera. You can see in the picture where the sclera is blue in color. So this pale blue sclera, other than osteogenesis imperfecta, it is also seen in other diseases like osteopetrosis, fetal rickets, Turner syndrome, Paget's disease, Marfan's syndrome and Ehlers-Danlos syndrome. These are all the diseases where pale blue sclera is seen other than osteogenesis imperfecta. And if you see dentin will here in the dentin also it will start to show opalescent dentin, that is brown color dentin will be seen, and which will affect both primary as well as permanent dentition. Before they used to consider this as dentinogenesis imperfecta. Now that the both genes in osteogenesis imperfecta and dentinogenesis imperfecta are different, so it is considered as opalescent dentin, and you can see in the picture. Other than these three important features, there are other features like hearing loss, which is called as hypoacusis, that occurs because of the osteosclerosis, which leads to compression of the nerves. That is why there will be hearing loss. And sometimes there will be hypermobility of the joints because of the laxity of the ligaments. And also there is a high tendency for capillary bleeding, even though the patients are not they are not associated with any bleeding disorders. So other than this, there are some head and neck manifestations also, like there will be large head size with frontal and temporal bossing, and along with that some dental manifestations like a class 3 malocclusion is very much predominant because of the maxillary hypoplasia. So as class 3 malocclusion is there here, there can be anterior and posterior crossbites and also open bite that is seen in osteogenesis imperfecta patient. So these are all general features that are seen in osteogenesis imperfecta. But there is a classification of osteogenesis imperfecta where it is a Sillens classification, where it is divided into 4 types based upon the different clinical features and genetic findings. And osteogenesis imperfecta, it is highly autosomal dominant in nature, but sometimes it can be autosomal recessive also. So let's see type 1 osteogenesis imperfecta. So type 1 is the most commonest and the mildest form of osteogenesis imperfecta, where among the patients, like 10% of the patients of type 1 osteogenesis imperfecta, they show prenatal fractures, and some features like blue sclera, mild to moderate bone fragility, kyphoscoliosis, hearing loss and bruising tendency are some of the consistent features that are seen in type 1. Whereas type 2, it is very much opposite to type 1, where it is the most severe form of osteogenesis imperfecta. So patients may not tend to live also, they die immediately after they are born. So they'll show extreme fragility of bone as well as fractures also. So 90% of the babies who are born will be stillborn, and even if they are alive, they die before 4 weeks of life. Such a severe is type 2 osteogenesis imperfecta. Whereas type 3, here opalescent dentin, blue sclera, limb shortening as well as some progressive deformities are some of the important features that are seen associated with type 3. And here 50% of the patients of type 3 osteogenesis imperfecta show in utero fractures, that is during the intrauterine life, embryogenesis itself, there will be fracture tendency. And type 4, more like normal things are there here, like normal sclera, normal hearing are seen, and in utero fractures are very rare. And the bones also, there will be mild angulation, and there will be shortening of the long bones that are seen as features in type 4. So these are the various clinical features that are seen in osteogenesis imperfecta in all the types. Next, let's see about radiographic features. So here if we take a skull radiograph of these infants or of the patients affected with osteogenesis imperfecta, numerous Wormian bones are seen. Wormian bones are nothing but multiple small sutural bones that are seen. You can see in the picture in the occipital region, numerous Wormian bones are there. And if you see long bones, there will be bowing and angulation of the long bones, like you can see in the radiograph there. And along with these features, there will be osteopenia and multiple fractures that are observed. And if we take a OPG, that is the jaw radiographs, there will be mixed radiolucency and radio opacities that are seen on the OPGs. This is about radiographic features. And under histologic features, as the bone formation is defective here, that is collagen form. So if you see here, this is the middle pink lacy one, that is the bony trabeculae. So instead of being bulky and big, they will show the bony trabeculae will be very thin and delicate, and they will be very much widely separated. And here, though osteoblasts and osteocytes they are present, the formation and organization of the osteoid will be deficient, because osteoid is the initially laid down that collagen, right? That is osteoid. So as this is a defect of collagen, so organization of osteoid will be deficient, whereas osteoblasts and osteocytes will be normal. So this is about osteogenesis imperfecta. Next, moving to a very important topic, that is fibrous dysplasia. So as osteogenesis imperfecta is a hereditary one, this is a non-hereditary developmental anomaly. So wherein the main why this fibrous dysplasia will occur is, here the bone which is formed, it will be replaced by fibrous tissue, and within this fibrous tissue we will see secondary metaplastic bone. So normal bone will be replaced by fibrous tissue, and within this fibrous tissue there will be osseous metaplasia that will occur later on. So why all these things are occurring? That is, what is the pathogenesis behind fibrous dysplasia? So that is because of a mutation in a gene called as GNAS1 gene, which is nothing but guanine nucleotide binding protein alpha stimulating activity polypeptide gene. So if we see normal activity of GNAS1 gene, it is present on the it is a so what it will do is first it will stimulate the G protein receptor which is present on the cell surface. So once this G protein is activated, it will activate the cyclic AMP which is present inside the cell. That is, cyclic AMP acts as a secondary messenger. So it has a tendency to stimulate three factors, that is maturation of osteoblasts, one thing, and second is it has endocrine function, and also it can stimulate the melanocytic activity. So these are the normal functions, but whenever there is a mutation in GNAS1 gene, there will be defects that are seen in all the three features, that is osteoblast, endocrine as well as melanocytic function. So the severity and the features of the disease will be seen when the mutation is occurring in GNAS1 gene, whether it is occurring in prenatally or whether it is occurring in the whether it is occurring in postnatal life. Okay, if it is occurring in prenatal life, that is if it is occurring early in prenatal life, that is within 6 weeks of intrauterine life, then the features will be, all the three will be defective, that is osteoblast, endocrine function, melanocytic activity, resulting in McCune-Albright syndrome. But if the gene defect is occurring late in prenatal life, that is after 6 weeks of intrauterine life, then it results in defect of only osteoblasts, that shows up as polyostotic fibrous dysplasia, that is multiple bones are defective. If the mutation in GNAS1 gene is occurring in postnatal life, that is after the baby is born, then it results in monostotic fibrous dysplasia where only one bone, any bone will be defective. So this is the pathogenesis of fibrous dysplasia. Now let's see clinical features of fibrous dysplasia. So firstly we'll see about polyostotic fibrous dysplasia. The name polyostotic, that means like multiple bones, 2 or more bones are involved here, and the most commonly it involves long bones, and these long bones defect will show pain, pathologic fractures, sometimes limping will be seen, and bowing deformities are very much commonly seen. And the main pathognomonic feature is that there will be curvature of the femoral neck as well as a proximal shaft, resulting in a deformity called as shepherd's crook deformity, and this can be observed when you take a radiograph of the this femoral region. As you can see in this picture, that bending, that bowing, that curvature near the femoral neck and proximal shaft, it looks like a cane in the hands of shepherd, which that is why it is given the name shepherd's crook deformity. And this polyostotic fibrous dysplasia, it is associated with various syndromes. First is Jaffe-Lichtenstein syndrome, where it is characterized by polyostotic fibrous dysplasia and caffeolate pigmentation. Caffeolate is nothing but coffee with milk pigmentation, which is the melanocytic activity deformity. So here both osteoblastic deformity is there, melanocytic activity deformity is there. This is a picture of caffeolate pigmentation, wherein if you see the borders of it, they are very much irregular, resembling coast of main appearance. And this caffeolate pigmentation, other than fibrous dysplasia, it is also seen in neurofibromatosis. Okay, and the next syndrome that is associated with polyostotic fibrous dysplasia is McCune-Albright syndrome, wherein along with this fibrous dysplasia, caffeolate pigmentation is there and multiple endocrinopathies are there. So that means to say that McCune-Albright syndrome, where all the three deformities, that is osteoblastic deformity, melanocytic deformity as well as endocrine function is defective. And the next syndrome is Maser-Brod syndrome. Here along with polyostotic fibrous dysplasia, there will be numerous intramuscular myxomas are seen. So these are the three syndromes that are associated with polyostotic fibrous dysplasia. Now let's look into monostotic fibrous dysplasia. So monostotic, that means only it is limited to a single bone, and it is diagnosed most oftenly during second and third decades of life. And the commonly involved sites will be craniofacial bones, ribs, femur and tibia. So if we see in the jaw involvement, maxilla is more commonly affected than mandible, and in the maxilla also posterior region of the maxilla is more commonly affected. And these maxillary lesions, they often extend to involve the other adjacent bones, that is zygoma, sphenoid and all, resulting in craniofacial fibrous dysplasia. And these jaw lesions, even if they occur as painless unilateral enlargement or unilateral swelling. That is the most common finding, and the growth of this enlargement also will be very slow in nature. If you see this picture, this is a painless unilateral enlargement of the maxilla, which is involving even the alveolar ridge. So this is about monostotic fibrous dysplasia. Now let's see the radiographic features, wherein the classic radiographic finding of fibrous dysplasia is ground glass appearance, as you can see in the picture. So ground glass appearance or orange peel appearance with poorly defined margins. Sometimes it can be fully radiolucent or mixed radiolucent to radio opaque also. If it is occurring in the mandible, there can be buccolingual expansion as well as bulging of the inferior border. These are the various radiographic features that can be seen. Histologic features next. So under the microscope, like it is fibrous dysplasia, so there will be defect in fibrous component as well as a bony component. Firstly, we will see the bony component. So here if you see, there are numerous trabeculae, right? So those trabeculae are very much irregular. So irregular trabeculae of the bone are seen, which are shaped in the form of C-shaped or Chinese character shaped. You see the picture here, there are these trabeculae are in the form of Chinese letter pattern. That is why it is C-shaped or Chinese character shaped trabeculae. And if you see these trabeculae under high power, they will either have oven bone, that is immature bone, or lamellar bone. But if lamellar bone occurs, it will be very irregular, okay? And as the bone formation here is not proper, so there will not be any osteoblasts which are seen along the trabeculae. So no osteoblastic rimming is seen. And if you see here along the trabeculae, there are some small clefts. So that is nothing but peritrabecular clefting, which is seen in fibrous dysplasia. And if you see, this is all is about bone. So where all this bone is present, it is present in the background fibrous stroma. So this fibrous stroma contains numerous proliferating fibroblasts with interlacing collagen fibers. As you can see in the stroma, right, blue cells are there. Those are nothing but fibroblasts with pink interlacing collagen fibers. The most consistent feature of this fibrous dysplasia is that if you see the periphery of the lesion, the lesional bone will be seen fused with the normal bone. This thing can give us that can differentiate it from ossifying fibroma, where there will not be any fusion. Next is cemento-osseous dysplasia. This is one more bone disease where it is considered as a fibroosseous lesion that is occurring in the tooth-bearing region. Whereas fibrous dysplasia is also a fibroosseous lesion, but it can occur anywhere in the body. Whereas cemento-osseous dysplasia, it occurs in the tooth-bearing region. And here, if you see etiology of cemento-osseous dysplasia, it is unknown. So no one knows the pathogenesis behind it. But because of its proximity of the lesion to the teeth, as well as the formation of mineralized product, that is cementum like material, like many authors considered that it might be due to the defect in the periodontal ligament, or it might be due to the defect in the extra bone remodeling, that is as a result of local or systemic factors. So these are the varied factors that are said under etiology of cemento-osseous dysplasia. And there are various types that are given under cemento-osseous dysplasia by WHO, that is into 3 forms based upon varied clinical features and radiographic features. So what are these 3 forms of cemento-osseous dysplasia? It is focal cemento-osseous dysplasia, or periapical, or it can be florid cemento-osseous dysplasia. Now let's discuss about clinical and radiographic features of individual type of cemento-osseous dysplasia. So firstly we'll see about focal cemento-osseous dysplasia. So name itself says focal, that means it involves only a single site, and these focal cementosseous dysplasia is most commonly seen in females, that is middle-aged females, and mandibular posterior region is the commonest region wherein the lesions are smaller than 1.5 centimeters in size. As their relationship with that of teeth is very much common, we can suspect a periapical pathology also. So vitality testing proves that this cementosseous dysplasia shows vital pulp. The teeth associated with them are shows vital pulp, and these are very much asymptomatic and can be found only on routine radiographic examination. And upon radiographic findings, as you can see in the picture, it can vary from complete radiolucency to good radio opacity. So actually initial lesions will be very much immature, that they show radiolucency, whereas later on mineralization occur, showing it might show radio opacity within them, as in the second picture. So that is about focal. Whereas the periapical cementosseous dysplasia, as you can see here, it is also seen in females. Here the site will be mandibular anterior region, that is apical periapical region of vital anterior mandibular teeth. Okay, so here the lesion can be solitary, like it can affect only a single anterior mandibular tooth, or it can occur in multiple teeth. So here also it is asymptomatic in nature, and if you see initially it can show radiolucencies like this, which are associated with the periapical region of mandibular teeth. But as the lesion progresses, that is as it matures, it might show dense radio opacities, and with surrounding these radio opacities there is this radiolucent rim also, as you can see. So this can happen later in life, that is maturity, because of the mineralization. So next is florid cementosseous dysplasia. This compared to the other two, it is multifocal in nature. That means it can involve both maxilla and mandible, that is all the four quadrants can be involved, and commonly seen in posterior region, but it is not like anterior region should not be involved, even anterior region can be involved. And at times the lesions are distributed bilaterally and symmetrical in nature. Here also many at times it will be asymptomatic only, but sometimes it might show pain and draining sinus because of the exposure of the sclerotic bone. And if you see radiographs, as you can see in this radiograph, where all the four quadrants are showing multiple areas showing radio opacities. So this is a picture of mature florid cementosseous dysplasia. So how does it look histologically? Cemento-osseous dysplasia. So bone will be defective and cementum-like particles are seen. So the first thing, those are nothing but globular cementum-like calcifications, which are cementoid deposits, mineralized cementoid deposits that are seen. Along with that, the trabeculae, bony trabeculae, which are seen here, they show curvilinear bony trabeculae. That is, mature lesions will show curvilinear bony trabeculae. Other than these two, numerous hemorrhagic areas can be seen within the stroma. So hemorrhagic areas are seen within the stroma, and the stroma will be cellular connective tissue. Cellular, that means numerous spindle shaped fibroblasts are seen. As you can see in this picture, the background, numerous small cells are there. Those are nothing but spindle shaped fibroblasts. So this is about cementosseous dysplasia, and altogether in this part of bone diseases we have discussed about osteogenesis imperfecta, wherein there is a defect in type 1 collagen resulting in immature bone formation. Next is fibrous dysplasia, which is a very important topic, and it can come as an essay also. So where there will be bone will be replaced by fibrous tissue, and then secondary osseous metaplasia can occur. And next is cementosseous dysplasia. This is also fibroosseous lesion, wherein it will occur most commonly in relation to the teeth, that is vital teeth, and it is of three types, that is focal, florid and periapical cementosseous dysplasia. So these three are things which are discussed in this present discussion.